You are 32, or 36, or 28. Your knees ache on stairs. Your fingers are stiff in the morning. Your hip catches in a way it did not 2 years ago. You mention it and someone laughs. You're too young for joint pain. You mention it to a doctor, and they say it's probably overuse, posture, the desk job. What almost no one tells you is that joint pain before 40 is not early aging. It is a symptom, and it belongs to a specific list of conditions, several of which are progressive, several of which are treatable only if caught early, and at least one of which can damage organs that have nothing to do with joints if it goes unaddressed long enough. The joints are not wearing out ahead of schedule. They are sending a signal, and the age at which the signal appears is part of the signal. The reason early joint pain is clinically significant is that its mechanisms are fundamentally different from joint pain in older adults. In people over 55, the most common cause is osteoarthritis, cartilage worn down over decades of mechanical use. It is degenerative. It is explained by years of loading. A 34-year-old does not have that accumulation. When a young adult's joints ache, particularly multiple joints, particularly with morning stiffness lasting more than 30 minutes, particularly with swelling or warmth, the cause is almost never mechanical degeneration. It is almost always something the immune system, the gut, or the metabolism is doing to the joint from the inside. That distinction, inflammatory versus degenerative, changes everything about the diagnosis, the treatment, and what happens if it is missed. Rheumatoid arthritis carries an association with elderly hands and decades of progression. The reality is that its peak age of onset is 30 to 50. It is frequently a young person's disease that gets dismissed as something else for years. It is autoimmune. The immune system produces antibodies that attack the synovial membrane lining the joint. The synovium thickens and inflames. It produces enzymes that erode cartilage and bone. The joint is being destroyed from within. The earliest symptom is morning stiffness lasting more than 1 hour, not the brief stiffness of muscle soreness, but a genuine prolonged inability to use the hands or feet that only eases with movement and warmth. The joints involved are typically small and symmetrical, both wrists, both knuckles, both balls of the feet. Matching joints on both sides is one of the diagnostic criteria. What makes early detection critical is that the bone erosions of rheumatoid arthritis are irreversible. A 2019 study in the Annals of the Rheumatic Diseases found that a delay of just 3 months between symptom onset and treatment significantly increased long-term joint damage. Every month of untreated inflammation is months of erosion that will not reverse. Ankylosing spondylitis is the condition most likely to be missed, and the delay between symptom onset and diagnosis averages 8 to 10 years. 8 to 10 years, in a condition that can fuse the vertebrae of the spine into a rigid column if untreated. It predominantly affects young men between 17 and 35, and produces a back pain unlike any mechanical back pain in almost every respect. It is worse in the morning and after rest, not after activity. It improves with movement. It wakes the person in the second half of the night with stiffness that requires them to get up and move. It has been present for more than 3 months. It began before age 40. This pattern in a young person is ankylosing spondylitis until proven otherwise. Yet it is routinely treated for years as a disc problem or poor posture. Because X-ray changes take years to develop and early disease is invisible on plain film. MRI detects the sacroiliac inflammation before it becomes structural. In a young person with this pain pattern, an MRI of the sacroiliac joints is the appropriate first investigation, not a plain X-ray and reassurance. Ankylosing spondylitis also causes uveitis, eye inflammation that can cause permanent vision loss in approximately 30% of patients. The joint disease is the presenting problem. The systemic inflammation is the long-term risk. Psoriatic arthritis affects approximately 30% of people with psoriasis, but the joint involvement can appear years before the skin condition is obvious, or in skin locations rarely examined: the scalp, behind the ears, the navel, the gluteal fold. A person with joint pain who has never been told they have psoriasis may have it somewhere they have never checked. The distinguishing findings are specific: dactylitis, swelling of an entire finger or toe so that the whole digit becomes sausage-shaped, is a hallmark. Enthesitis, inflammation at the point where tendons attach to bone, produces heel pain at the Achilles insertion or the bottom of the foot that is frequently misdiagnosed as plantar fasciitis. The distal joints at the very tips of the fingers are involved in ways rarely seen in other inflammatory arthropathies. Critically, rheumatoid factor and anti-CCP antibodies are typically negative in psoriatic arthritis. A normal standard blood panel does not rule it out. The diagnosis requires clinical recognition of the pattern, not just a blood test result. Reactive arthritis is missed because by the time the joint pain appears, the trigger has been forgotten. It follows a gastrointestinal infection, Salmonella, Campylobacter, Shigella, or a sexually transmitted infection such as chlamydia. The infection clears. 1 to 4 weeks later, joints become swollen, painful, and hot, typically in the knees, ankles, and feet, typically asymmetrically. The connection between a bout of diarrhea 3 weeks ago and a swollen knee today is not one most people make without prompting. Most reactive arthritis resolves within 6 months without permanent damage, but 15% becomes chronic. Asking specifically about recent gastrointestinal or urogenital illness in a young person with acute joint swelling is a question that changes the diagnostic picture, and it is not always asked. Lupus presents with joint pain as its earliest symptom more often than it presents with anything else, and it is capable of causing kidney failure, cardiac involvement, and neurological damage if the underlying inflammation is not identified. It affects women at 9 times the rate of men, most commonly between 15 and 44. The joint pain is migratory, moving between joints rather than persisting, and involves the small joints of the hands and wrists symmetrically. It rarely causes visible destruction but produces significant pain and stiffness alongside fatigue, skin rashes on sun-exposed areas, hair loss, and mouth ulcers. The ANA test is the screening tool. It must be specifically requested. In a young woman with joint pain, fatigue, and any of the systemic features described, it is not optional. Because lupus treated early is a managed condition. Lupus treated after kidney inflammation has progressed is a different situation entirely. Gout is appearing in people in their late 20s and 30s, with increasing frequency, driven by fructose consumption, dietary patterns, and metabolic syndrome arriving earlier in life. The demographic assumption that gout belongs to older men is wrong and is causing misdiagnoses in younger patients. The attack is distinctive. Acute, severe pain that builds to maximum intensity within 12 to 24 hours. The joint is red, hot, swollen, and so sensitive that the weight of a bedsheet is intolerable. The big toe joint is the classic site, but ankles, knees, and wrists are all valid locations. The danger is treating the acute attack without investigating the underlying uric acid metabolism. Left unaddressed between flares, crystal deposition accumulates in and around joints, eventually causing permanent structural damage. A uric acid level is a simple blood test. It belongs in the workup of any young adult with acute single-joint inflammation. The blood tests that matter in young adult joint pain are not complex. A full blood count, ESR and CRP for systemic inflammation, uric acid, rheumatoid factor, anti-CCP antibodies, ANA with reflex panel, and HLA-B27 for suspected ankylosing spondylitis. Together they cover the primary diagnostic possibilities. None are exotic. A plain X-ray is the wrong starting point for most of these conditions. The structural changes appear late. Inflammatory markers and autoantibodies appear early. The right question to bring to a doctor is not whether joint pain is normal at your age. It is what specific tests will tell us why it is happening. You are not too young to have a joint problem worth investigating. You are exactly the right age for the answer to still matter.